RAMAMURTHY, who's going to be talking to us on phakic IOLs, like what are these important tips which we need to keep in mind when we are doing phakic IOL in a normal eye as against an abnormal eye, and how you would manage some of those challenging moments. Thank you.
A very good afternoon. I'll be covering on phakic IOLs, the ideal approach in normal and abnormal eyes. It will be largely a video-based course, and phakic IOL implantation, most of you must have done this, and loading of, especially if you talk about the ICLs, the loading of the lens is the most important thing that you need to learn. And this is just the lens which is dispensed in nowadays in balanced salt solution. So there is no enlargement of the lens. It's taken out of the small bottle of water in which it comes and then placed in the cartridge. And after the placement, you are using a front loading forceps to gently draw it forward. Actually, you pull the cartridge back and the lens should come forward and almost brought to the edge and left there. And this is a couple of modifications that I've been doing for the last 2-3 years. In the sense, I do not dilate my pupils before the surgery, simply because all of us have, with years of experience in phacoemulsification, very rarely while making the incision there is a sudden touch of the anterior capsule. It's no big deal because you can include it in the capsular excess, but in a phakic IOL, fortunately it has never happened to me, but just in case it happens, that will be the end of the case because the lens would be damaged. So I like to have the pupillary iris cover on the lens, and then this is just the incisions being 1 millimeter incisions being done at the 3 o'clock and 9 o'clock meridian. I am seated temporally. That's a little bit of saline being injected. This is a 3 millimeter incision being made. I always make a 3 millimeter incision because I don't want a wound assisted implantation. Subsequently, this is a phenylephrine and a xylocaine mixture that's injected. And usually in these young myopes, the pupils dilate very well. And what I'm using now is a cohesive viscoelastic, and you can see an excellent dilatation that is there. This is the lens being implanted, and it's important that you ensure that the leading right optic has the small hole over there. And in case you're using the Indian lenses, the indicators are a little different. We'll come to that. And these are the lenses being positioned, and this is the only step that you need to learn differently from what you do in other anterior segment surgery, where you have to gently tuck the lens from behind. And as I'm just hydrating the wounds, you can see the viscoelastic, which is a cohesive viscoelastic, completely flowing out. Once clear fluid starts coming out, I know the viscoelastic is completely drained. There have been questions as to whether there could be viscoelastic captured behind the optic of the lens. But in about 3 years that I've been doing this routinely, this works very well for me. And whenever there's a toric intraocular lens, which is almost 75% of my cases, then there's a Varion overlay that's used. It's hardly an edited video, and as you can see, it just takes about a minute and a half for me to complete the case. And if bilateral implantation needed, we go on to the next eye with a completely different set of instruments with the a separate nurse coming in, and I also change my gloves and my apron before starting the next surgery. And just in case many of these young patients have astigmatism with the rule, and in case it's a small astigmatism of about 0.575 diopters or less, then I even go ahead and shift from the temporal aspect to the superior aspect. And since I make a 3 millimeter incision, I find that this gives me a compensation, especially when it is made superiorly, almost about 0.5 to 0.75 diopters of compensation you get. So you can even implant a spherical lens. Even though the incision is made superiorly, basically I'll dial the lens so that it's in the horizontal white to white, because that's how you have taken the measurement. So this is a little bit of a cost saving as far as the patient is concerned, and seems to address low amounts of astigmatism quite adequately without resorting to toric lenses. Though it's important that whenever you have significant myopia, hyperopia with toricity, you have to deal with it completely, because even small amount of cylinder left behind leads to dissatisfaction in the patient. As far as the toric phakic intraocular lens rotation is concerned, You can see the Varion overlay here, and this is the toric markings on the lens, and this is a Indian toric lens, which also we quite commonly use. And as you can see over here, the alignment is not really perfect. The time you realign these lenses is whenever the residual spherical equivalent is almost zero, because when you are placing these lenses, realigning these lenses, you are not introducing any power or taking any power, but redistributing the power. So if it is -1 with +2 diopters of cylinder, then this rotation is going to help. But if it's just -2 diopters of cylinder, it's a basic error in the calculation of the lens, and the lens replacement may be what is necessary. And I do not introduce any viscoelastic, just go in with the irrigation cannula, and with the digital overlay. Of course, you can do it with the manual marking also. I just go ahead and rotate the lens to its new position. And just in case you have the residual refractive error and the new position of the lens and the shift by which it has happened, instead of just putting back the lens in position, and in case you feel that lens is almost in position, still there is residual error where the spherical equivalent is almost zero, you can refer back to the company and they'll get back to you information about how many degrees that lens has to be rotated. And coming on to the less than ideal situations where we use phakic intraocular lens, something like an iatrogenic keratoectasia. As you can see here, it's a well-centered cone, and basically the patient underwent a smile procedure. Surprisingly, 5 years later in one eye developed a iatrogenic keratoectasia, and you can see the significant spherical and cylindrical error that the patient has. We did an intact procedure with CXL on him, and then subsequently the cornea got regularized, and the best corrected visual acuity was 6.9. We go ahead and use these phakic intraocular lenses. Nowadays it's not a this is an approved indication for using phakic intraocular lenses. Only if the best corrected visual acuity is 6.9 or better, and more importantly if the cones are centered, in the sense that more than 50% of the cone in the posterior float is in the central area. There have been situations where the cone is slightly decentered, but even if the visual acuity, best corrected visual acuity is 6.9 or better, that would also be an indication for using these toric lenses. That's just that case with a inferior intracorneal ring segment, where we are introducing a toric intraocular lenses to take care of the residual cylinder. So essentially, this is a 3-step procedure where the first and second step are done together. Collagen cross-linking for stabilizing the cornea, for the intracorneal ring segment, for centering the cone, and subsequently the toric intraocular lens implantation 6 to 12 months later for visual rehabilitation of these patients. Just in case the coning is not so extreme, but still it is somewhat decentered, you can see over here, I would like to center this here, as Chitra was alluding to earlier. You can do a collagen cross-linkage with the topo-guided PRK, and once this gets, you can see the significant, it's almost a regular bow tie with the rule bow tie that you have here. And you can, most importantly, the best corrected visual acuity from 6.18 has improved to 6.9 plus. So this eye is now ready to be rehabilitated with a phakic intraocular lens. Similarly, you can see over here a more severe degree of refractive error, but the best corrected visual acuity is just 6/12. And I am going to go ahead and with an CXL and an intact procedure. Please understand that the amount of cylinder has gone up from 1.5 to 4 diopters. That doesn't matter to me. The more important aspect is that the cornea has got more regularized, and the best corrected visual acuity has improved from 6.18 to 6.9. Once this has happened, then even this degree of ametropia can be dealt with quite adequately with a phakic intraocular lens. And whenever you're doing keratoconus, there can be chances of lens being oversized, simply because if you are taking only the central AC depth, like in this case, and if you have a central cone, you could get the AC depth as much as 4 millimeters, but there can be peripheral crowding. It has been suggested you can get multiple readings from the periphery also, but then there's no algorithm that's available to size your lenses according to the measurements that are taken peripherally. So what we do is to just go 1 step or 2 steps down. In the case of ICL, it will be 1 step down because it's 0.5 millimeter steps. And in a case of IPCL or an ICL lens, it will be 2 steps down because they come about 0.25 millimeters steps. And when we reduce this by 0.5 millimeters, it seemed to work well. As you can see here, this is a high vault in the two eyes, and as when it comes to an exchange, all I have to do is to bring the lens out like this, and just bring one of the haptics out, and subsequently bring with a hand over hand technique, just get the lens out, and a lens which has been undersized is going in, and that's a fairly routine surgery. You can also use post-corneal transplant.
We have to conclude.
Yeah, especially you have to be cognizant of the fact that that the endothelium, there should not be minimal damage. So use good amount of endothelial protection also, and go ahead and implant these lenses. And low vault and cataract, just because there is low vault, if the anterior capsule is quite clear, then we do not go ahead and do anything about it. I'll skip this video about this cataract surgery post-ICL. So in our quest for an ideal refractive correction, I think phakic IOL is a useful tool, and deep understanding of its limitations and challenges is essential. And for a modern day refractive surgeon, to be a complete refractive surgeon, it's essential to incorporate this in their armamentarium. Thank you so much for your attention.
Thank you, Dr. Ramamurthy.